Welcome to Roadmap to Residency. Today we are covering pancreatic and biliary disorders for Step 2 clinical knowledge. This is not a comprehensive review of the material. Instead, we will focus on high-yield question stems and test-taking strategies that will help you crush these questions on exam day. Make sure to review your primary study resources like First Aid, UWorld, and AMBOSS for the full details. If you find this video helpful, please like and subscribe, and check out our expert tutors and residency advisors at roadmap2residency.com. Let's dive in. These are our learning objectives for today. First, we want you to recognize classic question stems for the major pancreatico-biliary conditions. Second, we want you to apply test-taking strategies to eliminate wrong answers and pick the best diagnostic or management step. Third, master buzzword recognition to quickly narrow your differential. And finally, use your primary study resources to learn the underlying pathophysiology in detail. This video is about strategy, not memorization. Let's start with our framework. When you see abdominal pain on a question, ask yourself two key questions. First, where is the pain? Epigastric pain radiating to the back screams pancreas. Right upper quadrant pain points to the gallbladder or bile ducts. Second, what is the time course? Acute onset after a fatty meal suggests biliary colic or cholecystitis. Acute with fever and jaundice is an emergency, think cholangitis. Chronic weight loss with new diabetes in an older patient is concerning for pancreatic cancer. Recurrent episodes with steatorrhea indicate chronic pancreatitis. Now let's talk about buzzwords. For acute pancreatitis, look for epigastric pain radiating to the back plus elevated lipase plus a history of alcohol or gallstones. For ascending cholangitis, the classic Charcot triad is fever, jaundice, and right upper quadrant pain. If they add hypertension and altered mental status, that's Reynold's pentad indicating severe sepsis. For pancreatic cancer, the buzzwords are painless jaundice, palpable non-tender gallbladder called Courvoisier sign, new onset diabetes, and weight loss. Let's work through our first case. A 45-year-old man with heavy alcohol use presents with severe epigastric pain radiating to his back. He is nauseous, vomiting, and tachycardic with epigastric tenderness. His lipase is markedly elevated. What is the most appropriate initial management? Take a moment to think about this before we go through the answer. This is classic acute pancreatitis. The triad is epigastric pain, radiating to the back, nausea and vomiting, and elevated lipase at least 3 times the upper limit of normal. Patients often lean forward for relief. Remember the mnemonic I get smashed for causes. Idiopathic, gallstones, ethanol, trauma, steroids, mumps, autoimmune, scorpion stings, hyperlipidemia, and hypercalcemia, endoscopic retrograde cholangiopancreatography, and drugs. The correct answer is aggressive intravenous fluid resuscitation with lactated ringer solution. This is always the first step. Let's walk through the multiple choice options. Option A, abdominal computed tomography scan is wrong because you do not need imaging to diagnose pancreatitis when lipase is elevated. Option B, urgent endoscopic retrograde. Cholangiopancreatography is only indicated for gallstone pancreatitis with concurrent cholangitis. Option C, aggressive intravenous fluid resuscitation is correct. Fluids are always first. Option D, empiric antibiotics are not indicated without evidence of infected necrosis. Option E, surgical consultation for necrosectomy is premature without evidence of complications. Here is the test-taking strategy. When you see epigastric pain plus elevated lipase, the diagnosis is made. Do not overthink it. Initial management is always supportive care with fluids first, not imaging or antibiotics. Computed tomography is reserved for patients not improving after 48 to 72 hours, or if you suspect complications like necrosis or pseudocyst. Right upper quadrant ultrasound is used to look for gallstones as the underlying cause. A few pearls on severity and complications. Scoring systems like Ransom criteria and the bedside index of severity score may appear on exams. Key indicators of severe disease are blood urea nitrogen greater than 20, rising hematocrit, and persistent organ failure. For complications, know that infected necrosis requires antibiotics and drainage. Pseudocysts develop after 4 weeks and are drained if symptomatic or larger than 6 centimeters. Hemorrhagic pancreatitis presents with grey Turner sign on the flanks and Cullen sign around the umbilicus. Case 2. A 52-year-old obese woman has sudden right upper quadrant pain 30 minutes after eating fried chicken. The pain radiates to her right scapula. She is afebrile with normal labs. What is the most likely diagnosis? This is biliary colic from symptomatic cholelithiasis. The pattern is postprandial right upper quadrant pain after fatty foods, radiating to the right shoulder or scapula. The episode is self-limited, resolving in 1 to 5 hours. Importantly, there is no fever and no leukocytosis. Remember the 4 F's for risk factors: female, 40, fertile, and fat. The key differentiator from cholecystitis is the absence of fever, normal white count, and self-limited nature. Cholecystitis has fever, positive Murphy sign, and pain lasting more than 6 hours. Case 3. A 48-year-old woman has right upper quadrant pain for 12 hours, fever, and nausea. She stops breathing in when you palpate under her right ribs. Labs show leukocytosis. What is the most appropriate next diagnostic step? This is acute cholecystitis. The pattern is prolonged right upper quadrant pain greater than 6 hours, fever, and leukocytosis. This is inflammation, not just a stone causing transient obstruction. The exam finding described is Murphy sign, which is inspiratory arrest during right upper quadrant palpation. This is pathognomonic for cholecystitis. The correct answer is right upper quadrant ultrasound. You are looking for gallstones, gallbladder wall thickening greater than 4 mm, pericholecystic fluid, and a sonographic Murphy sign. Management pearls for cholecystitis. Initial treatment is nothing by mouth, intravenous fluids, pain control, and antibiotics covering gram-negatives and anaerobes. Early cholecystectomy within 72 hours is preferred. If the patient is too sick for surgery, percutaneous cholecystostomy tube is the temporizing measure. If ultrasound is equivocal, hepatobiliary immunodiacetic acid scan is next to confirm cystic duct obstruction. Case 4. A 65-year-old man has fever, chills, right upper quadrant pain, and jaundice for 2 days. He has a history of gallstones. He appears toxic with fever, hypertension, and confusion. Labs show leukocytosis and elevated bilirubin. What is the most appropriate immediate next step? This is ascending cholangitis, a surgical emergency. The patient has Reynold's pentad, fever, jaundice, right upper quadrant pain, plus hypotension and altered mental status indicating septic shock. Infected bile behind an obstruction leads to sepsis and death if not decompressed. The correct immediate answer is fluid resuscitation and broad-spectrum antibiotics. After stabilization, urgent biliary drainage via endoscopic retrograde cholangiopancreatography is the definitive treatment. Let's walk through the multiple choice for definitive treatment. Option A. Emergent cholecystectomy removes the gallbladder but does not decompress the bile duct. Option B. Percutaneous transhepatic cholangiography is an alternative if endoscopy fails. Option C. Endoscopic retrograde cholangiopancreatography with sphincterotomy is correct. This is the gold standard for biliary decompression in cholangitis. Option D. Open common bile duct exploration is rarely needed today. Option E. Observation with antibiotics alone will not work without drainage. Test-taking strategy for cholangitis. When you see fever plus jaundice plus right upper quadrant pain, think cholangitis first. Stabilize the patient before any procedure. The immediate answer is always resuscitation, then drainage. The key differentiator from cholecystitis is jaundice. Cholecystitis has no jaundice and you treat with cholecystectomy. Cholangitis has jaundice indicating bile duct obstruction and you treat with endoscopic biliary drainage. The jaundice tells you the obstruction is in the common bile duct, not just the gallbladder. Case 5. A 70-year-old man has progressive painless jaundice for 3 weeks, unintentional weight loss, and new-onset diabetes diagnosed 2 months ago. He denies abdominal pain. His gallbladder is palpable and non-tender. Labs show elevated bilirubin and elevated cancer antigen 19-9. What is the most appropriate next diagnostic step? This is pancreatic cancer. The red flags are painless jaundice in an elderly patient, unexplained weight loss, new-onset diabetes in someone over 50, and elevated tumor marker. The classic sign is Courvoisier sign. A palpable, non-tender gallbladder with jaundice suggests malignant obstruction of the common bile duct. Gallstones cause a scarred gallbladder that cannot distend. The correct answer is abdominal computed tomography scan with contrast. This evaluates the mass and assesses for vascular invasion and metastases. Thank you for watching. If this video helped you, please like and subscribe. Check out our expert tutors and residency advisors at roadmap2residency.com. Good luck on your exam.